In this explainer, we're going to break down the absolute fundamentals of how to read a chest X-ray. By the end of this, you'll have a solid, clear framework for analyzing one of the most important images in all of medicine.
So here's our game plan. First, we'll dive into the absolute basics of how an X-ray image is even made. Then, we're going to learn how to get our bearings by spotting key anatomical landmarks. After that, and this is crucial, we'll run through a quality checklist. And finally, we'll learn a systematic way to divide up the lungs for analysis. All right, let's jump right in.
Okay, first things first. We've got to understand what we're even looking at. I mean, what is an X-ray? And how does the way it's taken totally change the image we see?
At its most basic level, an X-ray is really just a shadow picture. A beam of radiation passes right through the body, and different parts of you block it in different ways. Think about it. Really dense stuff, like bone, blocks a ton of that radiation, right? So it casts this bright white shadow. But the lungs, which are full of air, they're not dense at all, so they show up black. We're essentially looking at a two-dimensional snapshot of a three-dimensional person.
Now this is huge. The direction the beam travels totally changes the picture. The gold standard is the PA view, or postero-anterior. The beam goes from back to front. But for patients who are too sick to stand, we have to use an AP, or antero-posterior view, where the beam goes from front to back. Now here's the catch. The heart is at the front of the chest. So in an AP view, the beam spreads out as it passes through, which actually magnifies the heart's shadow. This can make a normal heart look way too big, a condition we call cardiomegaly. This is a classic trap for students, so you really have to be aware of it.
Okay, let's move on. Now that we know what an X-ray is, we need to figure out how to get our bearings. Before you can even think about finding what's wrong, you have to know what's what and where you are on the map.
All right, look at this. This is basically our roadmap. It is absolutely critical to know left from right. And thankfully, there are 4 key landmarks that'll let you nail it every single time. Let's walk through them together.
So, let's break down these 4 giveaways. First off, look at the right diaphragm. See how it's a little higher than the left? That's totally normal because the liver is sitting right underneath it, pushing it up. Then over on the left, you've got 3 dead giveaways. The aortic knuckle, that's the shadow of the aorta arching over. You have the apex of the heart, which points down and to the left, and often you'll see this little gas bubble in the stomach, just hanging out below the diaphragm.
Awesome. So we know which way is up. But before we go hunting for problems, we have to play the role of quality control. Before you can even begin to interpret an X-ray, you have to make sure it's a good quality film to begin with. This is the professional's first step.
And this slide shows our first quality check perfectly: rotation. Look on the left. In a good, well-centered X-ray, the spine is exactly in the middle of the collarbones or clavicles. The distance is equal on both sides. Now, contrast that with the image on the right. See how the patient is twisted? That's a huge problem because rotation can totally distort the anatomy and make normal things look weird, or even worse, hide something that's actually there.
All right, next up is exposure. Is the film too bright, too dark? You're really looking for that just right Goldilocks quality. And here's the trick. A perfectly exposed film lets you just faintly see the thoracic spine right through the shadow of the heart. If you can't see the spine at all, the film's underexposed. And if you can see it in crystal clear detail, well, that's overexposed, and that can totally wash out subtle but important details in the lungs.
And this all comes back to understanding the basic densities. Seriously, commit this to memory. Air is black, soft tissue and water, they're different shades of gray, and bone or metal, super white. Recognizing these different shades is the absolute foundation. It lets you ask the right questions. Is there too much white in the normally black lungs? Well, that could be fluid, that could be pneumonia.
Okay, last section. Let's talk about the patient's breathing, because that matters. And then how we actually map out the lungs to describe what we see.
A good chest X-ray has to be taken when the patient takes a really deep breath in, peak inspiration. But how do we check that? Well, we count the ribs. A good, full inspiration will show at least 6 of the anterior ribs or 10 of the posterior ribs sitting above the diaphragm. A little pro tip, the posterior ribs, the ones that run more horizontally, are usually a lot easier to count.
So that leads to a really important question. What happens if that rib count is off? Does it actually matter clinically, or is it just a technical thing?
Oh, it absolutely matters. This has real clinical implications. If you count less than 6 anterior ribs, that's a poor inspiration film. It can make the lungs look crowded and dense, and you might mistakenly think you're seeing something like pneumonia. On the flip side,
If you see way more than 6, that suggests the lungs are hyperinflated. They're overfilled with air. This can be a sign of diseases like COPD or asthma, where air gets trapped inside.
And last but not least, to make sure we're all speaking the same language when we describe our findings, we divide the lungs into these simple zones. We use the anterior ribs as our guide. The upper zone is everything above the second rib. The middle zone is the area between the second and fourth ribs. And the lower zone is everything below that fourth rib. It's a simple system, but it ensures everyone is on the same page when you're describing where you found something.
And there you have it. That's our basic framework. You now have a systematic way to walk up to any chest X-ray. You check the view, you orient the anatomy, you assess the quality, and you map the lungs. And look, this isn't just about passing a test. This is the critical first step before you can even begin to look for what's wrong, which, of course, leads to the next big question. Now that you can do all this, what are the subtle abnormalities you might start to look for?